Welcome back to the Your Go-To Doc YouTube channel. I'm Dr. Robert Feldman, board-certified neurosurgeon for over 25 years, here to talk to you about common neurosurgical problems that I'll see in my office every day, and I will basically be going over a conversation that I would have for you in my office as if you were my patient. And we're going to talk about today lumbar spondylolisthesis and lumbar instability. Not a relatively common problem, but something that I see regularly. And we're going to go over what is lumbar instability and spondylolisthesis, what kind of symptoms can it cause, what does it look like on imaging, like x-rays, MRIs, CAT scans, as well as your treatment options, including the surgical treatment and what to expect before, during, and after that surgery, as well as the risks and benefits. So follow along and we'll give you an appointment with your go-to doc and get you educated on lumbar instability and spondylolisthesis. So let's kind of take a guess as to the sequence of events that landed you in your doctor's office because of this problem and in turn led you to search for this video. Many years chronic backaches, the kind of backache that will flare up with activity, maybe improve with a couple of days of taking it easy, maybe some Motrin, a heating pad, and over the years that back pain has gotten more and more severe, accompanied by significant muscle spasms in the low back, and then eventually possibly leg symptoms where you would get shooting pain, numbness, and tingling down your leg in a specific pattern. Typically, these symptoms would occur after an activity that requires a lot of bending, twisting, or lifting. There may be an accompanying sensation of feeling loose in your low back, or something wiggling, or not the amount of strength that you'd expect when you're moving around in that lower back area. Sometimes this pain can be kind of a low-grade smoldering pain, or sometimes it can be so severe and acute that it literally brings you to your knees and you're stuck in bed for a week or two because the pain is so severe. So these symptoms eventually get to the point where you can't manage them on your own with over-the-counter medication, or they're interfering with your quality of life enough that you can't go to work, or you can't play with your kids, or you can't do the chores around the house or the projects you like to do in the yard. So you eventually make a phone call to your chiropractor or your primary care doctor, and you tell them your symptoms, and they start with some x-rays. And what they may notice on your x-rays is that the bones in your spine, called the vertebra, are not lined up perfectly on an x-ray. That in turn may lead to further x-rays where you're bending forward and then bending backward, called flexion-extension x-rays, and those x-rays demonstrate a significant amount of movement or wiggling in between the bones when you move forward and backward. So the position of the bones when you move forward and backward moves at a certain level compared to other levels in the back. That is called lumbar instability, and it basically means your bones are wiggling around too much. That is a very painful condition. If those bones wiggle around too much, the little holes between the bones that allow the nerves to come out can get smaller and get pinched, and that's when the leg symptoms occur. Typically, if that happens, you'll then get an MRI and probably a CAT scan and be referred to a neurosurgeon or some type of spine surgeon to talk about options for that problem. So you show up in my office, your back hurts, your leg hurts, your primary care doctor, your chiropractor, your pain management doctor discover that you have lumbar instability. What do I do with you? Well, the first thing I'll do is I'll show you your pictures, and we're going to look at some x-rays, an MRI, CAT scan, and we'll look at these things on those images. But first, let's take a look at some models of the lumbar spine to give you an idea of what can happen and why when the bones start to wiggle too much in the low back. So let's look at a normal spine model first. Okay, so this is the normal lumbar spine. These are the pointy things we feel down the back of our spine when we run our hand down the back of the middle of our back. These are the vertebra or spinal bones in the front of the spine right here. And you can see when you look on the side here that these bones are kind of lined up. There's a nice curve, which is normal, but the relationship of the front and backs of these bones are pretty lined up with each other. Other things to note are this hole right here between this bone and this bone. That space is where the spinal nerve comes out on either side. Now, the structures that keep these bones lined up properly, there are many of them. Some of them are ligaments that wrap around the vertebral bodies right here. Some of them are the facet joints and the ligaments that wrap around the facet joints. There's one facet joint, there's the other. And these are supposed to move a little bit, but not too much. And then finally, the structure of this bone right here compared to this bone, there is a structure that connects this part of the bone here that basically allows the components of these levels to stay in relationship with one another in a stable position. So this part of the bone right there and right there and right there is called the pars. And there can be a defect in the bone right there called a pars defect, which you can be either born with or develop from trauma. And if that bone is not connected right there, that means that this piece of bone right here is basically floating in the breeze. The joint right here where this bone connects with the lower one doesn't have any support to this bone up here. So it's this entire segment of bone here is not attached to anything. The only thing that's preventing it from flying away are the ligaments around this joint. Now, if we look on another model, you can see this more clearly, and you can also see the nerves. So here is, let's say this is the number 4 bone, this is the number 5 bone. There's the number 4 nerve coming out of the hole. That black line right there is the pars. And if, let's say, you have degenerative instability, that means this joint is becoming degenerative with arthritic changes over the years, and now the two bones can do that. So one moves forward on the other. This nerve gets pinched right here. This joint is not competent anymore. It's gotten loose and wiggly, and that allows these bones to wiggle when you bend forward, bend backward, for example. So that's one reason why you might get unstable and wiggle, because these two joints right here become incompetent. The other reason is, again, pars defects. If these two bones are not attached to each other, either you were born with it, which is called a congenital pars defect, or you fell out of an airplane, that's called a traumatic pars defect. That bone is not connected to that bone, and this whole segment right here is now floating and not attached to the upper bone here. And that means that all the support that you're relying on for these two bones to stay lined up comes from the ligaments that wrap around these two bones. These joints don't provide any support because that bone is not connected right here. So that's a lot to ask for these ligaments to do. That's why if you're born with pars defects, until you're maybe 20, 25 years old, you don't have any problems because the tissues down here that are strong and tight provide all the support you need. But as you age, these start to get loose and degenerate, which they normally do. And because they're acting all by themselves to keep this area stable, you don't have this back here to help. These two bones start to get loose and wiggle. And that's why people with congenital pars defects can often develop instability in their spine at younger ages, mid to late 20s, early 30s. Whereas if you have structural support here with no pars defect and you get instability here, it's usually from degenerative disease in the joints here. These ligaments just get loose. They don't provide a lot of support anymore. These ligaments around the bones get loose, and you just start to wiggle here. So on the model, that's what spondylolisthesis looks like, which is where the bones are not lined up, and instability, where they wiggle when you move. So again, spinal instability just means the bones are wiggling around too much. Spondylolisthesis means that the bones are not lined up properly on imaging. And then finally, there's another word we can throw out that sounds big and fancy, and that's called spondylolysis. Spondylolysis is just the scientific medical term for pars defects. Lysis means up to break or to cut. So a break in the pars here is called spondylolysis. Not lining up properly on imaging of your bones and your lumbar spine is called lumbar spondylolisthesis. And wiggling too much on flexion extension x-rays is called lumbar instability. And that's what all that looks like on the spine models. So now let's take a look at what lumbar instability and spondylolisthesis and even spondylolysis looks like on imaging. Let's start with some x-rays. So here we have some x-rays of the lumbar spine, and this is called a lateral image, which means a side view. So if we look here on the left image, we see the squares, which are the bones, and the spaces in between the squares, which are the discs. These are the pointy bones we feel running down our back. So this is the back of the spine. This is the front. And here we can see between the forebone and the fivebone, the back of the bones and the front of the bones line up pretty well, and the disc space height is pretty healthy. If we compare that to the picture on the right, we see not only are the bones closer together than a normal disc like this one above it, but the back of the number 4 bone is forward compared to the back of the number 5 bone. And this step off here is called a spinal slip or a spondylolisthesis. Another important thing to note is that the bone connecting this part of the vertebral body area, which is called the pedicle, to the lamina here, which is, this area is called the pars, as I mentioned before. There is no defect in the pars here. The pars is a solid block of bone right here. So that would suggest that this slip here is a degenerative spondylolisthesis, which is simply coming from these joints becoming loose or less competent as we age. So this is an x-ray on the left of normal. This is an x-ray on the right of some spinal spondylolisthesis in the lumbar area. Now we don't know whether this is a stable or unstable spondylolisthesis because this is a static image where the patient is in a neutral position. So we would need to check for them to bend forward and bend backward to take pictures to see if this changes at all. If this changes, it suggests instability. So we know there's a slip here, we just don't know if it's unstable yet. Now in this x-ray, we again see the number 4 bone and the number 5 bone are not lined up properly. The disc space height is a little better than the previous x-ray we looked at. But here what we can see is that pars defect. You can see a break in this channel of bone right here. If you compare it to a normal pars here or here, you can see there's a separation here. And this patient was probably born with this pars defect. But what this means is that this bone here, associated with the number 5 bone, is kind of floating in the breeze. It is not structurally connected to the number 4 bone, which means that the body can't rely on this connection for stability and support. Instead, we're relying on this facet joint right here, which is basically worthless because this piece of bone is not connected to this piece of bone. And what that does is it causes a lot of stress on the ligaments that wrap around the bones here, and you're relying on those structures alone, along with some muscles and tendons around the area, to maintain support. Over time, these get worn out and the bones start to slip and wiggle. So this is an example of a pars defect, otherwise known as spondylolysis, leading to a step-off or slippage of the bones here known as spondylolisthesis. So on this x-ray, we get an example of what instability looks like on flexion and neutral positioning. So the picture on the left, the patient's kind of standing upright with no bending forward or backward, and you can see the amount of step off between the 4 bone and the 5 bone. When they bend forward, you can see that that distance increases. The front of the disc space in the neutral position is kind of normal, and the front edge of the number 4 bone doesn't overhang the number 5 bone as much as in this picture on the right where they're bending forward. The disc space collapses and this bone is now overhanging, the 4 bone is overhanging the number 5 bone in the front a lot more than in this picture, and the gap here has widened. That suggests that there is not only spondylolisthesis, which means the bones are not lined up, but there is instability, which means the bones are actually wiggling too much. You can see in neutral and flexion, the next 2 bones above, or the disc space above, you don't see that wiggling like you do down here. Here's another example on flexion and extension as opposed to neutral and flexion. Here's with the patient bending forward, here's with the patient bending backward. The amount of the slip changes fairly significantly compared to the bones above and below. That's called spinal instability. This is going to lead to back pain. When these joints in the disc here and these joints back here in the facet joints wiggle around and move around, it inflames the sensory joints inside those, the sensory nerves inside those joints, and can give you back pain, not only from the wiggling going on in these structures, but all the muscle spasm back here that your brain creates in order to stabilize this area. All of those things are going to cause pain. So now let's look at a CAT scan, which is very good at looking at the bones. This is an example of spondylolisthesis. The slippage here between the 5 bone and the 1 bone. This is lumbar number 5. This is sacral number 1. And you can see the number 5 bone is kind of digging into the number 1 bone. You could even argue maybe the bones are starting to fuse a little bit here. The disc space is a little sliver of space here. And this is an example of what spondylolisthesis looks like on a CAT scan. Of note, by the way, you can also see the white discoloration of the bone at the bottom of number 5 and the top of number 1. This is called reactive end plate change, and this is the bone's response to excessive force and pressure here. This is sclerosis of the bone, and it is basically a reaction of the bone tissue itself to abnormal forces at this juncture right here. Here's another CAT scan of spondylolisthesis, or slippage of the bones, 5 bone, 1 bone. This is a picture moving more towards the side instead of the center of the spinal column, and that's when we will get to those structures called the pars, and this is an example of a pars defect. This bone is supposed to be a continuous block of bone, but you can see this break right here. Again, probably a congenital, or the person was born with it, pars defect. And one of the ways you can tell this is the bone looks like it's kind of sclerosed on the edges here, which suggests this is a long-standing problem. And the bone is remodeled to have a nice kind of smooth, white-colored, dense edge here. So again, this is a pars defect contributing to structural weakness in this joint between the 5 bone and the 1 bone, thus leading to eventual slippage down here at L5-S1. Of note, you can also see the foramen, which is the hole for the nerve here, is a smaller and abnormal shape compared to the foramen up here. This can lead to eventual pinching of the nerve in this hole and leg pain. We'll take a look now on an MRI to really get a picture of what that pinched nerve can look like and what spondylolisthesis looks like on an MRI. So this is an MRI of the lumbar spine. Again, a lateral, or what we call sagittal view on an MRI. The squares are the bones. The discs are these stripes in between them. Discs are the shock absorbers. Here's the spinal cord right here, which ends about here. And then all these little stringy things down here are the nerves that eventually go out to the legs. In this case, we see a slight bulging disc between the L4 and L5 bone. And then down here between L5 and S1, we can see that the number 5 bone is too forward compared to the number 1 bone. There's a step off here between L5 and S1. The corner of the L5 bone, the back corner, is digging into the disc or top of the S1 bone. The front part of the L5 bone is overhanging S1. The number 5 bone has a white discoloration in it here. The number 1 bone has a white discoloration in it here. The disc is bright in here. There's a little bit of disc sneaking out, squeezing out from the slip here. And this is an example of L5-S1 lumbar spondylolisthesis. As a side note, I know very intimately what this feels like because this is actually an MRI of my lumbar spine. Yes, I have spondylolisthesis at L5-S1, and I do get back pain from this. Now let's take a look at an MRI that's further out to the side, showing the hole that the nerve comes out of here and it getting pinched by the piece of disc that's being uncovered by this slip. So here is the same MRI of my lumbar spine moving out to the left, and here you can see the number 4 nerve free as a bird inside the hole between the L4 and the L5 bone. Here's the L4-5 disc, this black stripe. But at L5-S1, the bones are practically touching, a piece of disc has squeezed out, the shape of the hole for the number 5 nerve is abnormal, and here you can see my number 5 nerve on the left getting squashed by this piece of disc, pooching out from this slip here, and that number 5 nerve looks like it's getting flattened and pinched, and I can assure you that this can cause left leg pain. So again, this is called pinching of the number 5 nerve, or foraminal stenosis. Foramen is the hole the nerve comes out of. Stenosis means pinching. And this is because of that slip between the number 5 bone and the number 1 bone. And of note, I do have pars defects, so you can just make out the little break in the bone here, which you don't see here. And then finally, just a more severe example of spondylolisthesis. Here is the number 4 bone, here's the number 5 bone. This is an MRI. And here you can see the slip has gotten so bad that the spinal canal with the nerves in it has got this kind of S or Z shape here, and that can actually cause significant pinching of the nerves, especially if this moves when you bend forward or backward. But this is a more severe example of L4, L5 spondylolisthesis. And then just to finish up with a image diagram rather than x-rays, CAT scans, or MRIs, this is again a side view of the spine. This gray silvery thing here is the disc or shock absorber in between the vertebral body above, the vertebral body below. Here is the foramen, the hole that the nerve comes out of. Here's the nerve coming out. And because of this slip, again, you can see the step off here, that hole is getting squeezed or pinched, and that nerve is getting irritated. And again, imagine bending forward and this bone moving forward and this bone moving backwards. That hole will get even smaller. And that's why people with unstable or wiggling spondylolisthesis will get potentially leg pain and more severe back pain when they just move. So this is just a diagram of lumbar spondylolisthesis. So you're in my office. We know you've got instability. We know you've got spondylolisthesis. We know your back hurts, your leg hurts. I show you your pictures. The next thing to talk about is why did what I show you on your pictures, why is it causing the symptoms you have? Well, keep in mind that there's multiple sources of pain that can come from problems in your lumbar spine. With spondylolisthesis and instability, you've got stimulation of sensory fibers in the disc space and the facet joints that are basically rubbing around too much. Those nerves can send messages up to your brain that says it hurts. That can in turn stimulate the inflammatory cascade, so all these chemicals rush in that cause inflammation, which is your body's way to respond to traumatic injury. That will stimulate nerve fibers to cause pain, and that's why things like anti-inflammatories can be helpful. And then all those signals going up to your brain saying, hey, it hurts down here, your brain says, all I can do to kind of help you guys out down there is try and keep things more still in that area, because it's the wiggling and moving around that's causing pain. And the way I'm going to do that is I'm going to tighten up all the muscles in your back to stop that area from moving as much and hopefully cause less inflammation. So the next area that can really cause pain is all that muscle spasm. And when all those muscles are seizing up without your permission, it can build up lactic acid in the muscles, and that in turn causes that severe muscle spasm pain. And that's a third or fourth reason for pain because of this problem. And then the final reason for pain can be movement or collapse of that disc. Movement of those bones can make the hole for that nerve that comes out of that area smaller and pinch that nerve. That can cause pain, numbness, and tingling. If it's really bad weakness, that can travel down the leg in a particular distribution, and that particular distribution is based on which nerve is being pinched. The number 5 nerve is going to hurt and feel numb in a different area than the number 4 nerve. Not everybody's exactly like the textbook, but typically these nerves have very kind of specific patterns that go down your leg. All of them, however, will also cause back pain. So that's why it hurts. So the next question we go over in the office is, well, what do you do about it? Well, you've got 3 basic options on what you can do about the symptoms that are coming from this problem. Option 1 is do nothing. Put up with it, try not to think about it, avoid the things that make it aggravated. Usually by the time someone sees me in my office, they've tried option 1 already and it's not working. But technically that is an option. You can basically just do nothing and tailor your lifestyle to avoid the things that really aggravate it. And most people, like I said, before they see me, they've been through years of option 1. And the reason they're in my office is because they've passed that point. So option 1 is typically not something we deal with in my office for this kind of problem. Doing nothing. Not really a choice for most of the people that I see for this problem. Option 2 is something called conservative therapy, and that basically means anything but surgery. Anti-inflammatories, muscle relaxers, pain medication, physical therapy, chiropractic therapy, heat, ice, massage, hanging upside down, traction, inversion therapy, acupuncture, and then finally pain management with injections. And those injections can be steroid injections, which are like a super strong concentrated anti-inflammatory drug put around the nerves in that area, or it could be, for example, facet blocks or facet rhizotomies. That's where you either numb up with a facet block or you permanently burn the little nerves in the facet joints. That's the rhizotomy, to stop the pain that comes from the rubbing of those joints in the back of the spine from sending a signal to your brain that they're upset. These facet blocks and rhizotomies and even the steroid injections, and actually all of the conservative therapy options, really don't fix the structural problem in the back. It doesn't fix the step off of the bones. It doesn't fix the wiggling of the bones. It doesn't fix the traumatic events that are leading to the inflammation. All those options in option 2, conservative therapy, really just mask your symptoms. Now, surgery, of course, is a last resort, so you definitely want to try a lot or all of those things in option 2 before you consider the surgery, especially for this problem, because the surgery is a relatively big surgery. But again, most people by the time they get to see me have tried that already. If they have not, I will often recommend that they try physical therapy, they try strengthening exercises, they try wearing a back brace, they try injections. And that way, if those things don't work or stop working or don't work well enough, they can sit in front of me and we can actually tell each other we've tried everything else before we start talking about the surgery, which is option 3. So let's talk about option 3, surgery for lumbar spondylolisthesis and instability. So what is the surgery to fix lumbar instability and spondylolisthesis? Well, if your bones are wiggling around too much and that wiggling is causing pinching of either the nerves or the spinal canal, then the solution to stopping all that is to, number 1, unpinch the tight spots, and number 2, stop those bones from wiggling. Now, the way to basically make the bones not wiggle is to get them to fuse solid together so they don't move anymore. And that's called a lumbar fusion. So the surgical solution to spondylolisthesis and instability is a lumbar decompression, unpinching, and lumbar fusion, getting the bones to meld into one solid bone so they don't wiggle anymore. So how do you do that? There are actually many ways to do that surgery. You can go all from the back, you can go all from the front, you can do a combination from the front and from the back. My personal preference is to do everything from the back. Number one, it allows you to unpinch things fairly completely, and you can be sure that you've unpinched things compared to if you go from other directions. Number two, if you're going to be in the back unpinching things anyway, you might as well keep the same approach if you're going to be fusing things also. Why roll the patient over and have another incision in the front versus the back type of thing? Now, I'm going to show you what this looks like on models and pictures, but keep in mind that patients that have pure instability but no pinching can get away with having a surgery from the front only, or a lot of it from the front and only a small amount in the back, or patients that have pinching only because when they wiggle, the hole gets smaller. You could technically go from the front, stop the wiggling, and if you stop the wiggling, the hole won't get smaller and the nerve won't get pinched. So technically, indirectly, you can stop the nerve pinching by just stopping the bones from wiggling. There are nuances to which surgery is the best for what problem, but I'm going to kind of give you the example of what I typically see. And then if we have time towards the end, I'll talk about these kind of rare exceptions where you can get away with something different. But let's talk about the typical patient who comes in, they're in their 50s or 60s, they either have degenerative or congenital spondylolisthesis, and not only are they wiggling, but because they've been wiggling for so long, they've built up a lot of arthritic changes like bone spurs and ligaments getting thick and cartilage bulging out that are pinching the nerves. So not only do they need things kind of cleaned out and rotor-rooted out so that the nerves aren't pinched, but once that's done, they then need stabilization by fusing the two bones together. So let's talk about how we would do that. Okay, so the first step in the process of fixing this problem would be to unpinch any tight spots. So to do that, I would do something called a laminectomy, facetectomy, and foraminotomy. Laminectomy means to remove the lamina, facetectomy means to remove part of the facets, and foraminotomy means to make the foramen, or holes that the nerves go out of, bigger. So what would that look like on a model? So here is the back of the spine, pointy bones in the back. One's missing right here because I've removed it. I've removed this bridge of bone here, which is called the lamina. You can see the space where that used to be. So that would provide me a window to look and see the nerves. And I could also trace the nerves as they go out this hole right here. So basically, after I remove all these bones, I would remove the ligaments, I'd remove any bone spurs that have grown, I'd make sure the holes feel nice and free, and I would clean out the holes on both sides. And that laminectomy, facetectomy, and foraminotomy would probably take about an hour and a half to 2 hours to do, to clean out all that stuff. The worse it is, the longer it's going to take. So that would be the first part of the surgery, the unpinching part. The next part would be cleaning out the disc. So on this model, and just ignore the screws here for a second, you can see the disc space has been cleaned out of all the disc material. All this has been cleaned out down here. And then I take a cage or spacer and I would place that in between the two bones here. And that spacer looks like, what did I do with it? Looks like this. So that is a intervertebral body spacer. They come in different sizes. You can see they're kind of bullet shaped so that you can tap this into that disc space. You can also see it's hollow in the middle. You can also see little teeth on the edge right there. And that they're angled in a direction so that once you tap it in, it's hard for it to come out. And that spacer goes in there. I usually put one in on the left, one in on the right. I retract the nerves over to the side to get that in there. And what I do is I take the bones that I removed from back here, I grind them up in a little blender inside the operating room. I mix them with some special stuff that makes bones grow fast together, and I pack that inside this spacer, and then I stuff it into the disc right there. And that, you basically pick the size spacer that's the right height to separate these bones and make them normal again. Because usually these two bones are too close together in the spot that we're working on, and we want to jack those bones apart. Keep in mind that the space for the nerve here comes from the space between these two bones. So if you raise these apart by stuffing this space with an interbody spacer, you can then indirectly make these holes bigger, which makes the nerve less pinched. So now I've unpinched the nerves. I've cleaned out the bad disc that it really isn't working anymore. I've packed the spacer that I picked based on its size with the bones that I borrowed from back here, as well as some special stuff that makes bones grow together fast. I've tapped that into the disc. I've elevated the space in between these bones and made these holes bigger. Now that everything's unpinched, the holes are bigger, the disc space is spread out, the anatomy is normalized. Now I want to keep it that way. We already know that these structures aren't working very well because the patient's wiggling. So now my goal is to fuse these two bones together. Now a good way to get bones to grow together fast is to keep them still. That's why you break your arm, you break your leg, they put it in a cast. The way we keep the bones still in the back is with the screws and the rods. Before we had these screws and rods, if you just put these spacers in and you've got bone, spacer, bone, and packed inside there is your own bone, and our ultimate goal is to get these two bones to grow together, without the screws and the rods, the statistical chance that the bones would successfully grow together was much smaller than with the screws and rods. So after I unpinch the nerves, after I clean out the disc, after I put in the spacers, I would then sew the patient back up, probably a 2-3 inch incision that I did all this through, and then through smaller incisions on the sides, I'd put in the screws and the rods. Now in the old days, the way I used to do this was a big incision, scrape off all the muscles from the bones, visually see that spot where the screw's going to go in, which is right there, where the transverse process meets the pedicle, and it would travel through that bridge of bone into the vertebral body. I used to visually see all this. Now I don't do that anymore. Small incision to do the unpinching work and the spacer work, sew that up, and then small incisions, 4 different incisions, little, to put the screws in. And that's done through something called minimally invasive percutaneous screw placement. Minimally invasive means the incisions are small. Percutaneous means I'm doing it by poking through the skin. And screw placement means putting the screws in. So how do I do that? That's using x-rays to guide little wires down the spot where I want to put the screws. Now the wires are confirmed to be in the correct place using x-rays, really called fluoroscopy, inside the operating room. So now I know the wires are right where I want to put the screws. The screws then just follow the wires down to the spot where they're supposed to go, and I can see on the fluoroscope that the screws follow those wires down. And the screws have holes in the center of them. This is not an actual pedicle screw, but you can see there's a hole in the middle there. And that screw will just follow that wire down until on the x-rays it's right where I want it to be. Then you can pull the wire out. Now the screw is sitting where it should be. So now you've got 4 screws in the spots that they're supposed to be, but because your bones are not necessarily lined up, they look like this from the side. Two of them are higher than the others. So what I do then is I put the rod on the lower one, clamp down the locking nut over the rod, and now your rod is horizontal like this, but the screw head for the upper bone is below it, because you've got the slip of your bones and your screws are like this. There's a special gadget that comes down over the rod and grabs the head of the screw and pulls it up to the rod. So what happens is as you crank that gadget, engage it more and more, the screw is pulled up to the rod, and because the screw is inside the vertebral body, the bones actually get lined up like they should, and then you lock down the nut on top of these screws, and now you're in good anatomy again. So it actually, what's called, reduces the spondylolisthesis. It reduces the slip. Lock down the nuts on the rods and the screws on this bone, pull the screws up to the rod on this bone, and now you're lined up again in good alignment, and then you lock everything down tight. So that is the final part of the surgery, where you actually stabilize everything with screws, which is kind of like putting a broken arm in a cast. You're putting your vertebral bodies in screws and rods so that they're locked and tight, and that allows those two bones to grow together that you put the spacers through. What you can also do at the same time is, before you close up these holes on the side, you can rough up the bones along the corners here and along the joints here, and put down some special stuff that makes bones grow fast together. And you can also get fusion on the sides here, and that's called a posterior lateral fusion, in addition to an interbody fusion. So that is basically the kind of theory behind what I would do in the operating room for this particular problem. So let's say you wanted to do that, how would it work? So if you decide you'd wanted the surgery, we'd get some blood tests, an EKG of your heart, a chest x-ray, make sure your primary care doctor says you're healthy enough for the surgery. You'd show up at the hospital, you'd meet the anesthesiologist, we'd bring you into the operating room. That whole surgery, to unpinch the nerves, put in the spacers, put in the screws and rods, takes anywhere from 2 to 4 hours, depending on how easy it is to unpinch things and how good the anatomy is seen on the x-rays. So again, 2 to 4 hours to do that surgery. Because of the new way that I do it, relatively new, with minimally invasive percutaneous screw placement, it doesn't hurt like it used to. The incisions are much smaller. The recovery is much faster. The hospital stay is much faster. And that's typically the surgery. You'd wake up in the recovery room. Back's going to be a little sore. Not terrible, but a little bit. You'll have a little button to press for pain medicine, so you don't have to ask the nurse for pain medicine. I typically take that away the day after surgery. 45 minutes in the recovery room, letting the anesthesia wear off. Then you'd go up to a regular room. First night, just take it easy. You're allowed out of bed to go to the bathroom, but that's about it. The next day, we get rid of the button, get you in a back brace, get you working with physical therapy in the hallways, and basically every day, walking a little bit more in the hallways, taking a little less pain medicine until you feel you're ready to go home. Typically, that's about 2 to 3 days after the surgery, I'd let you go home. I'll give you a relatively hard clamshell type back brace to wear, Velcro to tighten it. The first couple of days in the hospital, you're going to learn how to put that on and off really well, unless you got it early and you learned it at home. And basically, I want you to use that back brace only when you're vertical. You only need it when you're standing or walking. If you're lying in bed or sitting down, you don't need to use it. But I recommend keeping it on all day, and if you're sitting, just loosening it. But at night, you can just take it off. I usually will want you to stay in that brace for about 3 months. Anyway, you'll be back in my office about 2 weeks after the surgery for a checkup. My nurse will take your staples out of your incisions. I'll look at your incision. I'll ask you how you're feeling. We'll get some x-rays, make sure the screws and the rods look good, make sure the alignment is good. And if everything looks good on the x-rays and you look good, I would then let you start driving, short trips only, the bank, the post office, the grocery store. But basically, for the first 2 weeks, you want to be a slug. No bending, twisting, lifting more than 5 pounds, housework, yard work, hang gliding, skydiving. Lay low for 2 weeks, no driving for 2 weeks. Then, as I said, back at 2 weeks, I'll let you start adding some of those activities back as well as driving. You'll then be back again 4 weeks later, which is 6 weeks after the surgery, 6 weeks later, which is 3 months after the surgery, and then 3 months later, which is 6 months after the surgery. Each time I see you, we'll get another x-ray. If the x-ray looks good and you look good, I'll let you start adding activities back more and more and more. At 3 months, if the x-rays look good and you look good, we'll get rid of the brace. At 6 months, if the x-ray looks good and you look good, from my perspective, you've graduated, you're off the hook, you don't have to come back. Typically, by 6 months, I'll start to see on those x-rays that the bones are growing together. The surgical pain should be long gone by then. And typically what I tell patients is, it can take a good 3 to 6 months to really feel yourself after this surgery, mostly because of the trauma to the tissues from putting these screws in. What can happen is that the muscles that you have to go through to put these screws in are still lying on top of these screws. There's a big strap muscle that comes along here. And every time you move those muscles, it rubs on these screws and it can hurt. But over time, the body forms a capsule around these screws. And that capsule in real life is kind of shiny and slippery. And once that capsule forms, the muscles can move over the screws and not hurt. But again, it takes time for that capsule to form, usually a few months. So typically you'll be pretty sore for the first couple of weeks. Then you may notice that it's only at nighttime when you roll over in bed and you're not really paying attention that it's really sore. And then once that capsule forms, you can move those muscles all you want and you don't get that pain from the surgery. So that typically is the before, during, and after of that surgery. Now, the last thing we got to talk about before you consider the surgery option, of course, would be the risks of that surgery. So let's talk about that. So what are the risks of this surgery? Well, there are 3 risks that are for any kind of surgery. It doesn't matter what kind of surgery it is. Same 3 risks. Infection, bleeding, problems with anesthesia. All very low, especially for this kind of surgery, but it's in the book, so we have to tell you about those risks. And that's why we get the blood test, the EKG, the chest x-ray. Make sure you're healthy before the surgery. Even though we do all those things, those 3 risks can still occur. Infection, I typically will give antibiotics before and after the surgery, usually through the IV. And we use sterile instruments in a sterile operating room. And I also like to vigorously wash out all the incisions with antibiotic saline or irrigation fluid during the surgery. Bleeding, not much of a risk for this surgery, especially with the percutaneous method that I now use. Blood loss very minimal for this kind of surgery with that technique. Risk of anesthesia, more of an issue in elderly people with a lot of medical problems, but that is again why we get your primary care doctor to give us the green light, and we get an EKG, chest x-ray, blood tests, make sure your kidneys work, your blood clots properly, your heart's in good shape, that kind of stuff. And the main reason for that is the anesthesia for this surgery, 2 to 4 hours, can be a significant stress on the body. So those are the 3 risks for any surgery. There are a couple of risks that are special to this surgery because it's spine surgery. One risk is injury to those nerves. I'm working near them, trying to unpinch them. I'm putting spacers near them. I'm putting screws near the nerves. There's a risk that you could hurt one of those nerves with one of those things. Knock on wood, I've never hurt anybody's nerves before, but that risk is in the book, so we have to tell you about it. And that's why everybody for that 2 to 4 hours is my father, mother, brother, sister kind of thing. Everyone gets the same treatment. And that's why surgeons that do this kind of surgery have years and years and years of training. Every single surgery you have to put in 110%. No surgery is simple. So being careful is the way you avoid bothering the nerves. The next risk that's special to this surgery, but again a very low risk, is something called spinal fluid leak. The covering of those nerves not only keeps in the nerves, it keeps in spinal fluid. If you get a tear in that covering, that fluid can leak out and give you headaches. Typically, if you see that, you see it right away during the surgery. You see a clear fluid leaking out of a tear. You can put a little stitch in it, little patch on it, lots of ways to fix that. Again, very small chance, but it's in the book, so we have to tell you about it. And those are the 5 risks to that surgery. There are a couple of other issues that aren't necessarily risks that are associated with this kind of surgery. One is there is a chance that those bones never fuse together. Like I said, with the screws and the rods, that chance is extremely low. With the techniques that we now use of cleaning out the disc and putting spacers in under pressure and putting in the special chemicals and drugs that can make bones grow together fast, the risk of a non-union or failure to fuse between those 2 bones is pretty small, but it is a possibility. If that happens, you got to go back in and redo everything, which is not easy. The other risk or issue with this kind of surgery is that most people, especially with degenerative spondylolisthesis, where they have 2 bones that may not necessarily be lined up and may be wiggling, that isn't the only space that's not great. This disc up here and these bones and joints may also be arthritic. This one down here. They may not be causing significant problems, but they may not be perfect on your imaging. By fusing these two bones together and making them not move anymore, it does put extra stress on the disc above and the disc below. So by making these bones not move anymore, you're basically making this point the transition point between everything above it and this stable area here. It technically is not designed to do that, and what you can do is you can speed up whatever was going to happen down here as far as changes are concerned. So if you're going to have degenerative arthritic changes at this level, and they weren't going to give you trouble until you were 80 years old, if you get a fusion down here when you're 50, this could happen, give you trouble when you're 60 or 70. It could speed it up. What I tell patients is that if you fuse these two bones together, the statistical chance that things will get bad enough above it or below it that you would need another surgery is 20%. Another way to say that is there's an 80% chance you fuse these two bones together, you'll never need anything else up higher. But that is also why it's important, and why I usually tell people at the 3-month or 6-month post-op check that practicing good back ergonomics, even though we fix this problem, is still very important for all the other spots in your back that aren't perfect. So bending with the knees, not with the waist to pick something up, not lifting anything too heavy, avoid twisting and picking something up, avoiding high impact activities, getting good nutrition, not smoking, staying slim. All those common sense kind of things are important after the surgery, not only to recover from the surgery itself, but to keep those other problems above and below the spot that we fixed from speeding up and progressing to the point where you'd need more surgery. So those are the risks or downsides of the surgery itself. Overall, all those are pretty low risks. So let's take a look at some pictures of what a lumbar fusion looks like on some x-rays, CAT scans, MRIs, and diagrams. So now let's look at some images of what the surgery looks like to do a lumbar fusion for lumbar instability and spondylolisthesis. So in this picture, we can see on the left a back view of the spine. So you're looking from the back. Here's the spinal canal here. Here's the nerves coming out to go to the legs. And this is the disc here that has a hole cut in it. So you would cut the hole in the ligament, clean out this space, make sure that you don't bother these nerves here, and then you would take the spacer or cage, as I showed you before, and you would tap that into that space, and that's what it looks like stuck in there. And then you would do the exact same thing on the opposite side, and you'd stuff the space in between these spacers with bone products and pieces of bone from back here, and the inside of the spacer would also have bone in it also. So now instead of bone, disc, bone, you're going to have bone, bone, bone. And that space will be supported by the height of this biomechanical spacer right here. And over time, the ultimate goal is to get these two bones to grow together. And of course, a good way to get bones to grow together is to keep them still, and that's why you're going to put in the screws. So let's take a look at what a picture of that looks like. So in this picture, the spacer is in between the bones here, packed with your own bone and some special stuff that makes bones grow fast. Ultimate goal, get these bones to grow together and stop wiggling around. The way to keep those bones still so that growth happens quickly is the screws and the rods, and this is what it looks like with the screws and the rods being put in. And you can use the special instrumentation to pull the screw up to this rod to get these bones to line up properly again. This is a diagram of what the screws look like after they're put in. Now let's take a look at what this will look like on an x-ray. This picture on the left is a front-back view of the spine. So you're able to see the spacers here and the screws and the rods on either side. And then this is a side view or lateral view x-ray. And again, you can see the height of the disc space is normal again. The spacer is in here. There's actually two of them, but it looks like one. The alignment of the bones looks good, and the screws and rods are stabilizing everything, so these eventually grow together. And just for fun, let's take a look at an axial CAT scan view. So this is sort of as if a slice of your back popped up like a piece of toast and you're looking at it from the bottom up. So this is the vertebral body or bone. These bridges of bone here and here are the pedicles, and here you can see the screws going right down the pedicles, anchoring into the vertebral body, and then the heads of the screw are poking out the back with the rods locked in place. And this is what sort of an end-on view of the bone looks like with the screws in them. And then finally, this is probably 6 months to a year down the road. This is a AP view of a CAT scan or a coronal CAT scan view. And here you can see the screws in the slice of the picture that just look like little circles. But more importantly, in the space where the disc used to be, you can see bone has bridged between these two vertebral bodies. And this is what a good fusion looks like. Nice solid bridging bone. These two bones can't wiggle anymore. All the back pain associated with the wiggling and the joints rubbing against each other and the muscles going into spasm will stop because these two bones can't move anymore. This is a coronal section, and then if we look at a sagittal section, which is a side view, you can then see very good bridging bone across the 5 bone and the 1 bone. And this is going to stop these two bones from wiggling around, and this is a successful fusion. You can't see the screws on these pictures because you're right down the middle, so the left screws are further down or further in the picture, and the right screws are further out of the picture, so you're not seeing any of the screws here. But this space in the middle would be this space right here, not off to the side or off to the side. Yes, it looks like there's not any bone growing in here, but this is plenty of bone successfully bridging this space to give you stability. So again, CAT scan images of a good fusion. So we talked about what lumbar spondylolisthesis is and lumbar instability, also what lumbar spondylolysis is. Then we talked about what those look like on imaging. Then we talked about what kind of symptoms you'll have from that problem, your options for treating it, the surgical option, what to expect before, during, and after, as well as the risks. Relatively long video, but that is really what an appointment would be with me for this kind of problem. The surgery to fix it is a relatively complicated surgery with many steps. So we're talking a good 45-minute to 1 hour appointment, which is basically what you got at no charge. So I apologize for the length of the video. Feel free to skip around if it's too long or there are parts that you're not interested in. A couple of quick things to keep in mind. Again, there are other ways to accomplish the same goal of unpinching the nerves and fusing those bones together. You can go from the front, you can go from the front and the back, you can go from the side, you can go from sort of an angle between the side and the back. None of them are necessarily wrong or right, and they are specific to the individual. So if your surgeon does not kind of do or offer what I exactly described, don't think that it's wrong. Just have them explain their methodology of thinking. Why did I pick that approach to accomplish the goals? And I'm sure they're going to have a very good reason. The other thing I want to mention just before we end is that back pain from worn out shock absorbers without instability, I'm not a big fan of offering big lumbar fusions for that kind of problem. And the main reason for that is it's very rare that it's only one disc that isn't working well. Usually the discs above and below that are not working well either. So if you offer to fuse the one that looks the worst, you're going to make the one above it and the one below it that aren't perfect get worse even faster. And all of a sudden, the patient might have 6 months of feeling good, and then those other discs start to act up, and they're right back where they started, and all of a sudden they go back to the surgeon, and the surgeon says, I need to add another level to your fusion. That lasts a couple years, and then you're adding another level to the fusion. Oftentimes, the amount of back pain you end up having in the long run is worse than if you just treated the original back pain with conservative therapy. Now, there are patients that I will offer a lumbar fusion that just have a bad disc, and the criteria for me to do that is, number one, their quality of life has to be totally shot so that they can't really do anything they want to enjoy doing. Number two, they must have tried all conservative therapies and maxed those out. And number three, the other discs have to look relatively good. In other words, there's one disc that is clearly causing most of their back pain, and the chances of them getting away with not needing another fusion down the road is pretty high, or they have a good chance of a good 10, 15, 20 years of not needing another fusion. And those are the criteria that I would use to consider offering a big lumbar fusion surgery to someone that just has degenerative disc disease with no nerve pinching and no instability. So again, I know there was a lot of information. I know that was a long video. I apologize. But thank you for watching the Your Go-To Doc YouTube channel. I hope this was helpful. If it was and you think this was worthwhile, please like and subscribe to my channel and help me get those subscriber numbers up. And then I can start adding more videos. We'll branch out into the cervical spine, eventually some brain videos. And we'll go into maybe some other things that aren't necessarily surgical, but could be facing patients or families that deal with neurosurgical issues. So again, thanks for watching, and again, stay healthy.